Today, I'm with Dr. Sameena Rahman, also known as GynoGirl. She is a board-certified gynecologist, a clinical assistant professor of OBGYN at Northwestern, and an owner of a private practice specializing in menopause and sexual medicine. And today, we're going to get the facts on what should be happening at our gynecologist appointments at every major stage in a woman's life. Welcome to the Dangerous Women podcast, where the intersection of fierceness and femininity fuels empowerment. Our goal is to provide women with insights to unleash their power. Grounded in the 7 principles of self-confidence, we guide women to embrace their duality, delicate as a flower, yet powerful as a bomb. I'm your host, Colleen Conlon, inviting you to join me as we explore topics on health and wellness, empowering you to embody the essence of your dangerous woman. Sameena, what are the major benchmarks in a woman's life when her biology begins to change? What are the different stages we should be aware of when we are visiting the gynecologist and things should start to change?
Yeah, everything really surrounds around what's happening to us hormonally, because the hormones are really dictating a lot of what's happening from head to toe, right? We have estrogen receptors and from head to toe, testosterone, progesterone, all the sex hormones you can think of. And so if you think about the first time you learn about it is really puberty, right? So puberty is like a big point. I always say from my perspective, I'm a menopause specialist. So I always tell my patients, you get puberty talks, you should get peri talks as well. But, all the way from puberty to menopause, we're talking about potential shifts that happen because of different situations that are happening in your lifetime. And puberty is one of the biggest changes in my household right now. I have a 12-year-old and a 5-year-old girl, and I have a 14-year-old boy. And I always joked with my husband, after we had my first daughter, and I was like, oh man, I bet by the time she's hitting puberty, I'm going to be hitting perimenopause, and it's going to be a real shit show on her. Which is very much the case. So my daughter's not in puberty yet, but she is. But puberty is a big difference in landmark too for little girls. And so I think, learning about how your body's changing and how now your reproductive potential is there. It just seems like so much of it is around reproduction, right? That's how much we're sort of dictating what's happening in our world. But we are the sum total of more than just our reproductive abilities. So I want to make clear to that, but a lot of what we experience is based on that. And so you have that, and then your the years that you're reproductively active, that the premenopausal years, you have the chances of when you may then endure pregnancy. Pregnancy is a big hormone shift, it's up, huge levels of estrogen, progesterone, everything. And so that is a big shift. And then you have the dramatic drop, right? You have a dramatic drop right after pregnancy. And so your body goes through a lot in the postpartum, or the 4th trimester, as we refer to it now. And then that's when you start later in your 40s, sometimes in your late 30s for some patients, go through this perimenopausal transition. And it's interesting because people always say, how do you define perimenopause? Perimenopause literally means around menopause. And if the average age of menopause in the United States is 51 and a half, the years leading up to that, or for some patients, it's months, right? But for some people, it's years. And some people, it can be up to 8 years or more. And so for some patients, if they're going to hit menopause in their late 40s, absolutely, they could start perimenopause in their late 30s, or early 40s. But I would say averages around, 47, mid 40s, that kind of thing. But that transitional period is very difficult for a lot of women because you're having a lot of ups and downs with your hormones. There's no consistency. If you're during your reproductive cycle, you do have these shifts in hormones that we can, really determine based on where you are on your cycle. But what happens in perimenopause is your brain is super confused. It's hey, it's time to ovulate. Let's get some, eggs going. And all of a sudden you have a surge of estrogen. And then 2 months later, it's no ovulation and you have no estrogen, so it's you have these big hormonal shifts and decrease in amount of progesterone consistently. And so your body goes through a lot. The perimenopause transition is probably the most difficult for most patients, that and puberty, right? Girls have difficult time at puberty, women have difficult time at perimenopause. And then, of course, menopause is the 12 months without a menstrual cycle defined based on your reproductive potential still. And then anytime after that final menstrual period is postmenopause. And, you live a 30-year life potentially in that period of time. And it's a potential, this hormonally deprived state that, we don't address enough in the United States.
So there's so many stages, so many things are changing.
Yes.
And
Yes.
does that mean when we are visiting the gynecologist, things should be changing along with our body in those visits?
Yeah, I mean, totally. I think that we need to be able to, one of the big things I say that, I'm here to educate for you to advocate for yourself, right? Because don't expect anyone to save you. Like you have to be the owner of your own healthcare, right? As women, we put so much on our plate. We're responsible for so many people in our lives, and midlife women particularly, I think, are balancing like parents, kids, like, work potentially, all the crazy stuff. And then you're drastically going through hormonal shifts and people wonder why, like, she's irritable today or whatever it is, like whatever the case may be. But I think that, like, based on how your body's changing and what you understand about yourself, you know, you should see your gynecologist. I mean, the American College of OBGYN recommends your first gynecology visit to be anywhere between 13 and 15. And that doesn't mean a pap smear. That doesn't mean a pelvic exam. That doesn't even mean undressing. It could just be an educational session for them, but just to understand, for teenagers to understand what a normal menstrual cycle looks like for them. Because we are so ingrained to believe that women should suffer, that when women suffer indefinitely with pelvic pain or dysmenorrhea, pain with their menstrual cycle, they just think it's normal. And even though it's common, like you can talk to your girlfriends and they're like, yeah, I have, really bad cycles. I'm in pain all the time. And you think it's normal, but common doesn't necessarily always mean normal. So that's why you should just be in tune, with what's happening with your cycle, with the changes that you're having, and when to see the gynecologist based on that, But I think a lot of what we need to do more of is preventative, right? We don't do enough preventative work. It's always like, I have a problem and now I need to go see you. And I think that's why our healthcare system is so messed up. But if we can work more on, just educating about our own bodies and then understanding, what happens when things go wrong, then I think we do a better job, actually.
I think it's so interesting that you say, when you start going to see the gynecologist, little girls going through puberty, it's not necessarily the pap smear, it's getting the education. I remember I went to the gynecologist for the first time because I was having really painful periods. I was sleeping in the bathtub the first 2 nights of my cycle for the first
Whoa.
year. And then my mom was like, okay, we should probably consider getting you on the pill or something like
Yeah.
that. And that's
Yeah.
why I saw the gynecologist for the first time. And I remember as a teenager growing up, I was like, well, why do I need to see the gynecologist? I thought I'm only supposed to see the gynecologist if I'm starting to have sex and I'm not having sex, mom. So what's going on? And I'm scared and
Yeah.
I'm confused.
Yeah.
So
Yeah.
I think it's so great that you say, a girl going to see the gynecologist for the first time, it's educational.
Educational. Exactly.
So what happens after that? When should we actually start getting pap smears in that case?
Right now it's the consensus guidelines are still age 21. That may change actually, but it used to be 18, now it's 21. It's every 3 to 5 years, depending on what your situation is and what your results are and all that stuff. But I think that it's funny because I told you I specialize in menopause. So I have a lot of patients that come to me for their perimenopausal symptoms. And then they're like, hey, can I bring my daughter to see you because she's having all these issues? And are you gonna, and so a lot of them just bring their daughter in too when we talk, and we just do, even educating on anatomical terms, like understanding what's the vulva, what's the vagina, where you're at, I think just does wonders for women, because if you don't have the right terminology to explain what's happening to you, then you get a delay in diagnosis big time, right?
Mm.
So I think that's always important. And then, we do have talks about sex, like when you choose to do that, this should not be painful. This should be something that is consensual, all that stuff too. You have to address all those things. But at this point, yeah, still 21 is when we usually start pap smears. Some people will still get pelvic exams or screenings before then. For instance, if you are sexually active and you want to get screened for sexually transmitted diseases, some patients will have a pelvic from that, although you can also do it with the urine. So
Interesting. Okay.
I always try to minimize as much of, because, in the medical system, I feel like we have the ability to create trauma for women, right? Like pelvic exams, a first pelvic exam can be one of the most wonderful or most traumatic experiences for a patient, right? Like she can either, like from that point forward, say it's going to be okay, I can see my gynecologist again, or she's going to run for the hills and never want to go again. And I usually see patients the opposite who are like, I had a very traumatic first exam. It's been years and I just finally, got the strength to come. But I teach a lot of students and residents and stuff, and I tell them that I'm like, when you're with me, you're never going to do the first PAP exam on any patient, because I will not let them be traumatized by a student doing an exam, because they don't know what they're looking for half the time. But I think that we have to be cognizant of that. Like, that's what we call trauma-informed care when it comes to dealing with patients and all of the nuances of such an intimate situation.
In that case, can you explain to us what is a normal or I'm trying to figure out the word I'm looking for, but what should a woman's first pelvic exam actually be like? What should we be expecting in
Yeah,
case it's anybody's first time listening to this and they're scared and they
yeah,
want this information to know, this isn't weird, this isn't
right.
bad, this is what I should expect.
Right. And I think in an ideal world, I'll tell you how I do I do my exams. I'm very thorough and I have a private practice. I spend a lot of time with my patients. I don't find that, in a typical, like really busy gynecology practice, because I used to work in academics and I had to see 30 patients a day, and it wasn't anything that you could sit and really like take your time with, because the system is really rigged against that. You know what I'm saying? But in my practice, and I think in the most ideal situations, you actually verbalize everything you're going to do before you do it. So if I have a patient in for the first time and she's like, it's my first PAP, and I'm going to say, this is part of, I always talk to patients fully clothed initially. So they are in full understanding and they can pay attention. Like if you're half naked, you're just, you're not feeling comfortable. You're not actually, probably focusing in on what's being said to you. So I tell patients, we're going to, let me explain to you my full exam. If somebody is there and we do a breast exam, I tell them how I do the breast exam, or we have you lift your underarms, I, feel, and I'm just looking and feeling for abnormalities, bumps, lumps, or, discharge, anything like that, skin changes. And then when I talk to them about the pelvic exam, I'll show you, I have a vulva puppet here. I actually, I
What?
actually will.
That's
This is
so
my vulva
cool.
puppet. Yeah, I have many of these in my office in every room. And so when I have a patient, I'm gonna say, you know what, I just want to give you like a little basis of your anatomy before you start, so that you understand how we're going to do this exam. Because I do a lot of vulvar dermatologic skin conditions, I really focus on, like, first, we're going to just look at the vulva. I'm going to look at your vulva. I'm going to just see, that will include this labia majora, your labia minora. I'm going to retract your clitoral hood and make sure that I can get to the corona, the base of it, so that we can make sure there are no adhesions or scarring in that area. That can be a cause of clitoral pain or, orgasm dysfunction, for some patients. So I do say that I'm going to be retracting your clitoral hood, so you'll feel that. And then I always tell them, like, because I do so much the other thing I specialize in is sexual pain and sexual dysfunction. I pretty much do this standardly on every patient, even if they're coming in for an annual. I will do what's called a Q-tip test, which I will take a Q-tip and I will feel the vulvar vestibule. The vulvar vestibule is the area from the inner labia minora to, this is the vagina here. It's the area, but it's basically the entry of the vagina, the inner labia minora to the hymen remnant. And I'd say this is where you pee from. Right around that is your vestibular tissue. So I'm going to feel with the Q-tip, the soft part of a Q-tip, all the way around. And you're going to tell me if it feels like pain or pressure. And if it feels like pain, you're going to tell me what's the scale on a scale of 1 to 10. Now, I do this because patients that have sexual pain or pain, and specifically pain on initial entry, will have a lot of tenderness here. They'll say, are you touching me with a knife? Like, this is really burning. Like, what's that? And so for them to understand. And sometimes I'll say, this is how it should feel, and I'll put it on their thigh. Like, this is the Q-tip, this is how it should feel. And then they get an understanding of, what the vulvar vestibule feels like. And a lot of times I will, start to think, oh, this person, has pelvic floor dysfunction because they have a lot of pain down here. So then the next thing I do is I'll feel their pelvic floor muscles, and I'll do a sweeping here. And I'll feel if there's any knots or any tender spots, because a lot of us clench. If you clench your jaw, you're likely clenching your pelvic floor. If you're anxious, you're likely doing all that. So I always say, we're going to check your pelvic floor muscles. They're really helpful and responsible for, some abnormal urinary symptoms sometimes, bowel dysfunction and sexual dysfunction. So we're going to check all that. And I said, then after we do that inspection and early exam, I'm going to place the smallest speculum I have inside the vagina. And I'm going to look for your cervix. And I explain the cervix is the opening of your womb or your uterus. And that's how we're going to screen for the pap smear. I'm going to look at your cervix and make sure it's not abnormal. I'm going to collect some cells very quickly. I'm going to take the speculum out. And then I basically will do what's called a bimanual exam, where you feel internally, and you're going to feel from the abdomen as well. So you're going to try to feel the top of the uterus and the back of the uterus. And the goal is to see, like, does the uterus feel enlarged? Do I feel any masses in the ovaries? Because sometimes I've diagnosed, ovarian cysts that way, enlarged, or endometriosis. You can kind of sometimes feel some implants in the back wall of the vagina. So I kind of explain all of that to the patient before even having them get undressed. And then I'll ask them if they need a chaperone or whatever to accompany you, because you're allowed a chaperone anytime, you get seen. And so as a female, I feel like patients are less likely to ask for a chaperone. And I always have a student with me, so there's always like, a chaperone in there. But a lot of patients don't know that they can ask for a chaperone, just to be in the room with them. And so then I explain that to them, and then are you okay with all of that? And they're like, yeah, that sounds good. Thank you for explaining it. And then we do the exam. But I think it's really important to have that explanation.
Yeah, really important to have that explanation. Especially, I remember the first gynecologist I saw was a man, and
they're just getting right in there,
right in there, little me around like 13, and this 50 something year old man, and it was just like very uncomfortable. Didn't know what to expect.
Yeah.
My parents were not great about talking
Yeah.
to me about sex and the vagina and
Yeah.
what's going on with my body in general. So thank you so much for that thorough explanation of what should be happening.
And I think a lot of gynecologists may not, like, we never learned to examine the clitoris when I was an OBGYN resident. This is something that I've learned over time, just in the realm of the sexual medicine world. But, like, in theory, they should examine your clitoris, but they should tell you, like, I always say, like, I'm about to retract your clitoral hood, because you don't want to just like touch someone's clitoris without giving them a heads up either, it's a little off-putting otherwise. And the same with, like, doing an exam of the pelvic floor and all that stuff. But most people think a pap smear and a pelvic exam are synonymous, right? Like, oh, they had a pelvic exam in the emergency room and they assume they had a pap smear. But the pap smear specifically is a test that's done to get some cells from the cervix to assess for, like, precancerous cells or abnormal cells that could lead to cervical cancer. Basically looking for HPV.
Is it normal for a pap smear to be uncomfortable and potentially hurt?
I mean, it feels a little funny. It shouldn't really be like so painful, but if you're clenching your pelvic floor muscles and you're someone that's like really anxious and you're clenching your muscles, it's probably going to be uncomfortable. And so at that point, like, that's why it's really important to understand someone's history. Do they have a history of trauma from previous exams? Do they have a history of, sexual assault? Some of these things can trigger those negative responses, and automatically you will involuntarily contract your pelvic floor, and that can make the exam difficult from a clinician perspective and a patient perspective, because then you can't see what you need to see, and then you're maneuvering in there. And so I always, if I know a patient has had a history of trauma or sexual assault or any of that, I will actually offer them to put the speculum in. Do you want to put the speculum in yourself? And that's something you can ask for if you don't get offered. Like, is it okay? I don't do well with these exams, but I think I could put the speculum in. So once you're inside the vagina, then, you know, the clinician can manipulate to find the cervix. But sometimes it's just that initial penetration that gets people very anxious. And so, you know, that's kind of how we make sure that we're dealing with this in a trauma-informed manner.
Mm.
Yeah.
So, is there anything else that is going on at these exams that is potentially different than when we're transitioning into somebody who is figuring out that they're pregnant?
I mean, consistently, you'll have basically all of those, you know, like in theory, you should have all of that even at, you know, your first pregnant, you know, but sometimes things will look different. Sometimes the pap smear bleeds more in early pregnancy because the increased vascular flow to the area. You know, some patients I know, like I don't practice obstetrics anymore, but when I used to practice obstetrics, they would say like, please don't do a pap on me. I don't want to bleed. And so it's always became this negotiation of like, okay, you know, do we really need a pap? Number one, has it been within 3 years and you had a negative pap or whatever? And then two, like, you know, does the patient understand that the bleeding is not coming from the pregnancy itself, but from the cervix and the, you know, vessels from the cervix bleeding? It's the same thing when people bleed when they have intercourse during pregnancy. It's just like hitting up against, you know, a vascular cervix and it causes bleeding. But I think that some patients, you know, have a hard time with it, especially if they've had a miscarriage before, which again can cause trauma for a lot of patients. And then they don't want to do it until they know that. And I used to, when I was practicing, I'd say, you know, that's fine. We can wait and see. We see a fetal heartbeat and all that stuff. Because then in their mind, they always associate, right? I had this pap and then I had a miscarriage, even though clinically it doesn't make any sense at all. And that's not, but you know, that's the trauma that patients often experience. And so you work with them, right? You meet them where they are.
Thank you for clarifying that. Is there anything else where there's like a misconception in that realm as we're specifically talking about the bridge between going in for regular pap, getting ready to uh, reproduce before we dive into perimenopause?
You know, I think the main things are understanding, like, you know, do you even need a pap smear? And, you know, if your clinician decides to do one, and say you had a normal pap last year, and your clinician's like, well, I'm going to do a pap because A, I don't have the results, and B, like, you know, sometimes if you've had a new, because like really we're screening for HPV, right? I always say HPV is like the common cold of the vagina. Like 80 something percentage of women will get HPV at some point in their life. And so screening for that is, you know, usually via the pap smear. And so for some clinicians, they may choose to do a pap smear, you know, even if you say that you've had a normal pap last year, because sometimes patients don't get the results or they don't know for sure if it was normal, they just assume, or, you know, you may have a new partner and, you know, there's that possibility of a new exposure of HPV. So I think, you know, just understanding like, you know, do you need this or not? And, you know, if it's something that, like, I have patients who are very opposed to it and I'm going to meet them where they are, you know, like, I'm not going to force them to do something they don't want. That's just re-traumatizing. So I think that's very important to understand, like, the point of what you do in pelvic exams and why we're doing them. Like, you know, because a lot of, you know, even measuring the size of the uterus, all that stuff can be done via an ultrasound. So if you know, want to hold off on that, that's something that you might be able to negotiate, especially if you don't have like a significant history of, you know, HPV or whatever the case may be, or you've had a normal pap in the last, you know, couple of years.
And that's, you said a couple years, you said 3 years at what
3
point?
years.
3 years is this the standard?
Yeah. Yeah.
Okay.
Yeah.
And then at what point in time are women starting to have other tests done that maybe they haven't had up until this point? Is it one of the things I'm specifically trying to get at here is getting the mammogram? Does
Oh,
that need to
yes.
take place at, I've heard it needs to take place at 40. I've heard something
Mhm.
else recently when it's once I'm perimenopausal, that's when I should start to go in for the first one. Can you set the record
Yeah.
straight on
Yeah.
that?
And I think, you know, some of that really there's really no one size fits all overall, but what we do know is on average, you should have your first mammogram by age 40, right? But there are situations where I'll order an ultrasound or a mammogram earlier, right? So I always do a complete family history for patients. And if I understand that someone's had, 2 or more family members on the same side with breast cancer, 1 family member with breast cancer less than age 50 or premenopausal breast cancer, or 1 family member on that side with ovarian cancer, then I often will offer them genetic screening, right? Because we can screen for genetics. And it's not just the BRCA1 and 2, which are the more common ones you hear about. There's other mutations like check mutation. There's maybe like 30 plus mutations that some of the labs will do, and they'll assess to see if you have a genetic mutation that makes you more inclined to get breast cancer. So if the average woman walking down the street has a 1 in 8 chance of having breast cancer till they're 80 or 13%. Anyone that has greater than a 20% lifetime risk of breast cancer, which is determined through some calculations we can do. Sometimes it's determined based on if you have a genetic mutation that would make it more susceptible for you to have breast cancer. Because, some of these mutations, you have like an 80% risk of breast cancer. So all of those patients, you put in a separate category. You'll say, okay, you have this strong family history. The youngest member that ever had breast cancer for you was like age 43. I'm going to start your mammograms at age 33, 10 years before that. And we're going to really aggressively work to see if there's any possibility that this will happen to you. We find it very early, right? And if you have a greater than 20% lifetime risk of breast cancer as well, you're also, usually insurances will cover a breast MRI for you. So a lot of patients will get a breast MRI and a breast mammogram, basically every 6 months apart. And so that is something we offer patients, especially once we calculate their lifetime risks.
Is there any other tests that are being done at this point in a woman's life?
Let's see. We do clinical breast exams, right? Because sometimes as a clinician, I'll feel a bump or a lump, and then I'll say, okay, it's not time for, you're 32 years old, you don't have any family history, but I feel this bump in your breast. Let's get an ultrasound at least to assess. And so sometimes then the radiologist will say, I also just want to do a mammogram as well.
What would life be like if you could get that toned look? You could have physical superhuman strength by training with just 2 kettlebells at home. What would happen if you were on a program that strengthens self-awareness and courage so that you can develop a deeper connection and trust to self? What about this? What if you could be in a community with other women where you are encouraged to be assertive and resilient to build mental and physical strength? If you're waiting to hear what the offer is, this is it. Swing to Snatch, a 13-week kettlebell intensive, is my signature course that empowers women to get started with kettlebells. Work with me live in a virtual container guaranteed to grant you kettlebell queen status. To learn more, visit www.colleenconlon.com.
And then based on that screening, it might change how we screen you. So the clinical breast exam, I think, is very important. I think that, by the time you hit between 25 and 30, I feel like, you should have, especially depending on your family history and your ethnicity, you should start looking at your cardiovascular risks, right? Heart disease is still the #1 killer in women. So if we're looking at, someone like, I'm South Asian, we have a very high risk of cardiovascular disease. I'm going to make sure we've checked your lipid panel. Let's see what your cholesterol is. Let's see what your hemoglobin A1C is. Diabetes is rampant in your family, and sometimes we can suggest these things or know these things based on the fact that, like, your menstrual cycle, sometimes, like I always say, the menstrual cycle is like a vital sign. If it starts becoming too consistently off, that tells me something might be happening hormonally for you. And so if I detect, okay, someone's not having their cycle, it's like every 60 days, you might have X, Y, or Z in my mind, I'm going to make sure we check these other parameters too. But I think that's very important to have baseline labs like that at some point, after the age of 25, to make sure that you're, especially by the age of 30, no one's thinking of heart disease at that age. But once you kind of look at it, for the first time and understand that, because that is a total preventative thing too, right? Like, we're trying to prevent you from getting high cholesterol, which then leads to these plaques, which then leads to cardiovascular disease and compromise. And the same thing with other things like, smoking assessment. So many people are, because of it's legal in different states, are using cannabis regularly and they're vaping and all this stuff. So you do like those are like how you would do some more preventative assessments. But I think, other than those screening tests, and determining whether or not someone needs a test for sexually transmitted diseases, CDC recommends really anyone 25 or younger to have it done. And then after that, it's based on, new exposures, whether or not your lifestyle has rendered that you're using condoms, effectively, all of that stuff. But yeah, I think those are the big ones. And then, by the time you hit 45, that's the new age for colonoscopies now. So, we usually have patients refer to get a colonoscopy, a screening colonoscopy at that point.
I had no idea about getting the panels done. I've had panels done from my regular doctor, but I've never had a gynecologist recommend getting them done. And I'm 31.
Oh, yeah. So, and I think that's the other thing I ask. Like, do you have a primary care that does this for you? Because a lot of times, if you're only seeing one doctor a year, that one doctor may be your gynecologist, right? And so I don't necessarily treat high cholesterol or high blood pressure, but I will, assess for those things, right? And then I'll say, well, we got to get you in with the primary care so that you can get this taken care of. But, I actually, I'm a big person believing in prevention. And so like, I think, and because I think that, you know, again, because I deal with so many peri and postmenopausal women who never had this done, and when I do catch someone in their 20s and 30s, I'm like, has this ever been done for you? Do you want to do it? Like, like depending on what the patient, says. If they have a primary care, then I'm fine. Like, I'm sure they've had it done. But a lot of patients I see in their 20s and 30s and even early 40s have only seen a gynecologist their whole life,
Mhm.
So it's important, I think, to understand that. So they almost consider their primary care to be the gynecologist. So,
And is that a normal thing? Is that a good thing? Is it just like pick and choose your own adventure, or is there one that
I
you wish your clients were doing? Do you wish they were all just coming?
mean, I wish they were doing, I wish they had their own primary care, right? Because I feel like I can't provide you, this precision care for all aspects of your life,
Mm,
right? So I always do, like, I have a handful of primary care physicians that I refer to, but people's lives are busy and complicated, and, they come in for their birth control because they don't want to get pregnant, but hey, I have this window of opportunity. I have you in for an annual. Let's see what we can do. Like, is there anything else? And so sometimes I'll uncover stuff and I'm like, you have to see a primary. Like, this is something you have to do. But I think, it's the same with like, asking questions about like lower back pain or other things. Like sometimes I'll discover stuff in the spine that, wasn't discovered before or whatever the case may be. But, like I said, I think it stems from me, having my own practice and not doing obstetrics anymore. I think when you're in a busy OBGYN practice, I always tell perimenopausal women, like, because they need more time and they need more like, appointments because their fluctuations are happening and they have to see, the doctor more regularly. That if you go to an office and you're seeing only pregnant women in that office, unless there's one doctor that's really like the menopause person for that busy practice, then it'd be hard pressed to say that you would get the standard, the kind of care that you want in perimenopause. Because I've been there. I've been that OBGYN in that office, seeing 30 patients a day. And if someone has like, these lengthy issues, it becomes very daunting and troublesome to address in the limited time they give you when you work for a big corporation.
Now, I know we're not going to have the time to dive into all things perimenopause, menopause. I would love to bring you back, and I would love anybody who's listening to this right now. You have got to follow Dr. Sameena on GynoGirl. She has so much incredible information. I'm getting so much of my information these days from her podcast. But what should be happening when we think we might be perimenopausal? Is there anything that's now changing at these appointments? And you just mentioned they might be more frequent. So what is going on at these appointments?
Yeah, so I think it's interesting because of the fluctuations in like estrogen levels in this period of time, right? So standardly, you have your ups and downs with estrogen during your cycle. And, in perimenopause, because the number of eggs are being reduced, the quality of eggs are being reduced, you have some cycles where you may ovulate and release an egg, and some cycles where you may not, but your brain is trying to get your ovaries to do that. And so they stimulate your ovaries and cause these big rises in estrogen. So there might be 1 month where you have like headaches, breast tenderness, and heavy flow. And 3 months later, you're having hot flashes, like severe brain fog and vaginal dryness. And you're like, what is going on? And majority of patients that are in this period, like something like 80% have like neurologic symptoms, right? Or mental health issues or concerns, like symptoms. So either like brain fog, anxiety symptoms, depression symptoms. I mean, I have that as a primary reason that people come to me sometimes. Like, I feel like I'm going crazy, like, or am I having dementia? Like what is happening to me? I mean, it's really that cognitive distress that pushes a lot of them. Some of them push through vasomotor symptoms, which you shouldn't do either. But, they'll come to me and they'll say like, I have panic attacks. I've never experienced this before in my whole life. I've never been an anxious person. I can't get on a plane anymore. These are the kind of things that people are in so much distress about. And so because of these fluctuations, we'll find some way that they can take, if they're good candidates for hormone therapy, we utilize them, and then we check in on them every, initially every 1 to 2 months, and then maybe every 3 months. And then sometimes we have to adjust the dosing because, a couple months in a row, you've had really low estrogen, a couple months you've had too much bleeding, or, whatever the case may be. So there's a lot that goes into treating patients during that transitional period. And a lot of it is listening. Like I always tell my med students, like you can get so much just by listening to a patient, right? Like if you actually listen to things they say, it's like really like, oh, they told me everything I need to know. But unfortunately, like historically, women have been so gaslit by the medical system. I myself, being another doctor, has been gaslit by doctors. So it's not like, even, based on, your socioeconomic status or, knowledge base or whatever, it's just part of the system, I think, part of like patriarchy, I guess, like it's been, troublesome for a lot of patients. But I think that transition is so difficult. Then there's patients who complain about joint pain, muscle pain, frozen shoulder, like, we got to get them in the right, exercise regimen and get their diet, fixed for them because things are changing for them, so much. So it's a roller coaster. It's a very disorganized time in your life. And it's a time where you need to be kind of the most organized, right? Because like, elderly parents, young kids, like, work related stuff, everyone's depending on you, and it's really a lot for a lot of patients.
From your lens, is the way we manage this outside of, getting a healthy lifestyle in place? I would imagine it's, what you just said, the fitness regimen, the nutrition, maybe it's even like therapy, working on the mindset and managing stress. From the stuff that you do, is the answer always hormone therapy?
No, not always. A lot of patients are, and again, I meet patients where they are. First, I like to educate them on why, if someone is totally like a patient who can take hormones and they're in so much state of distress, but they're refusing it, I want to know why. Like, is there a reason specifically that you're scared of? Is it, oh, sometimes it's my mom never told me that I never had to use it. Why does she, she never used it. Why should I use it, kind of thing? Or I can get through this. I'm not going to give into hormone therapy or whatever the case may be.
What is hormone therapy? Like right now, I'm just like
Yeah.
imagining my pill. Like I take a pill
Yeah.
for birth control reasons. So is it like
Yeah.
that? Is it something else? I don't know anything about this.
Yeah, so there's hormone therapy. Sometimes we give in perimenopause can be in the form of oral contraceptive pills because you can still get pregnant. I just had a patient last week who was like 47 years old, perimenopause, going through a miscarriage, and she was like, I just didn't think I could get pregnant. I'm like, this is still possible for you. So that's why like my favorite is like doing an IUD, which will control bleeding and make sure you don't get pregnant. And then adding, something along the way if we need to, like an estrogen pill patch. So that's one form of it. And there's some birth control pills that are probably better than others for patients that are in the perimenopausal period. And then, as long as they don't have any reason they can't be on the pill, like, 45-year-old, heavy chain smoker kind of thing, like, or, obese and a chain smoker, something that would make us think twice about putting them on a birth control pill. Versus, menopausal hormonal therapy is much less hormone. We used to call it hormone replacement therapy, but we're not fully replacing your hormones. We're just giving you enough to kind of give you some symptom relief and some protective benefits, we think, So menopausal hormonal therapy can be in the form of a pill. It can be like estradiol. And if you don't have a uterus, like you've had a hysterectomy, then estrogen is the main thing you need. And then I also replace testosterone in patients who have low testosterone and they have sexual concerns. And then there's progesterone that you add when someone has a uterus. And I think progesterone, probably gets a bad rap in a lot of ways as just the uterine protector, but I think a lot of patients benefit from it in more than ways than just that, because the stuff that we give, like the oral micronized non-synthetic progesterone, is, really can have a calming effect on patients. It can help them fall asleep at night, which is a big disturbance in perimenopause. So that's sort of the menopausal hormonal therapy. We usually, most of us usually probably start with a transdermal route, meaning will absorb through the skin. So that can be in the form of a patch or a gel, or even vaginally. There is a ring that you can use in the vagina that helps with that as well. And I think that, I just work with the patient, work with what their insurance covers, work with what they think they can use. Like, so if you feel like, symptoms can be alleviated with this, and, you feel better on it, that's where I want to get you, because there's no need to suffer, right? We have become too accustomed to allowing women to suffer. I have so many patients that tell me stories about, oh, I wish I knew you when I was going through perimenopause, because every doctor I saw said, you've had babies and you've done X, Y, and Z, like this should be nothing for you. Or, like, it's like you've been through pain all your life. Why not just suffer a little longer? Like, it's really sad. It's sad, actually. We can be okay with it. And so it's kind of like one of those things where, like, when pregnant women are trying to decide if they should get an epidural or not, like, do I tough it out and like have these really painful contractions and blow out my vagina? Or do I have something that I can sleep through labor? Like, it's one of these things where I feel like it is a personal choice, and you should find someone, a clinician, that will allow you to make the decision together. Like, not just tell you, like, I never tell patients you have to have hormones. These are your options. This is the data behind it. Is there a reason that you don't want to do it? You let me know. We don't have to go that route. We can try these other routes first. And then if you don't succeed that way, we could try. And, like, it's really, a joint decision making. And I think optimally, that's how we should practice medicine, right? It should be based on that patient. We call it precision medicine in the menopause world. You do based on that patient, what's happening with them, their family history, and you make a joint decision together.
What happens if you happen to have a gynecologist who's kind of just like in and out, and you don't even know what questions you should be asking because they're so nonchalant in the session?
I think you need to find you probably need to find someone that can listen, right? Like,
Okay.
I think that there is, unless you have this great relationship with your gynecologist or clinician, whoever you're seeing, and saying, hey, listen, I really need this addressed. The one thing I can say is, if you're going to someone who has like an insurance-based model and you're going in for your annual exam, to say that you can get your annual exam and your menopausal or perimenopausal symptoms done at once, insurance-based models don't allow for that. Like, they won't cover one or the other. You have to do, so I always tell a patient who's like, I'm here for my annual, but I have all these complaints. I'm like, let's review your complaints first, because the annual is really just, we're going to do your breast exam and pap, and we're going to just make sure things look good, and we're going to do your pelvic exam. But with this list of issues, let us talk through what's going on and make this a consult instead. And I think it's really important for patients to understand that, because most of us don't understand what our insurance means. And so sometimes and a lot of menopause providers don't even take an insurance for that reason, because they don't get the compensation for menopause, doesn't allow them to keep their roofs, to keep them open. Actually, the overhead becomes too much for what insurances want to compensate them for.
And I know from listening to your episodes that you help women specifically with menopause. Not all gynecologists are necessarily equipped for that. Is that correct?
Absolutely. I think there was a study done last year just asking, it was family medicine, OBGYN, and internal medicine, like how many people that were surveyed like felt like they were equipped to, or they felt competent in treating menopausal or perimenopausal patients, and it was like 6%. So it's not a lot. You don't get a lot in residency. I think I saw a handful of menopausal patients. In medical school, you might get one lecture on it. We're trying to change that. I'm trying to, I bring in a lot of students into my office to try to help them see a lot of menopausal patients and sexual pain and sexual dysfunction patients. But that is an area of medicine that, and it shouldn't really, the onus shouldn't always fall just on the gynecologists. Like, internists see women in midlife, cardiologists, family practice doctors, endocrinologists, like all of them should have a better knowledge base on menopause. If you can't find that your gynecologist does, there's ways to find someone. There's the North American, what used to be the North American Menopause Society, is called the Menopause Society now. They have a list of, certified menopause clinicians. And then, a bunch of us that, we call ourselves the menopause on social media. But we're the ones always posting about it and speaking out against it. But I think that there's a lot of, my colleagues have websites that include lists of clinicians that are, good for menopausal therapy too, and perimenopause. So right now, I think it's, there's a lot of talk about it, and people are really like, getting out there to discuss it as much as possible. So it's a good time to get someone that can to listen to you.
So, on that note, is there anything that's happening when a woman is in menopause and she's coming to see you that is happening differently in an exam from any other stage in life?
Well, what frustrates me, I think, is that when I see someone in perimenopause or menopause that haven't had pelvic exams, like they'll get vaginal estrogen, the whatever, but no one's checked their pelvic floor, nobody's looked at their vulvar vestibule, nobody's looked to see whether or not, some of their urinary symptoms are attributed to lack of estrogen. Because we have this whole syndrome, the genitourinary syndrome of menopause. I think of it as more of hormone deficiency, because people that are lactating have it, sometimes people on birth control pills can get it. Like there's a large range of people that can get it at different points in their lives. But I think that, not getting that exam, just having a discussion around menopause is sometimes not enough, especially if you have genital urinary or sexual complaints. But, really a lot of it is, making sure they've had their preventative screenings. I have a lot of patients that come to me even after the age of 65 are like, they took my hormones away. Am I somebody that can get back on it? Then we just have a long discussion about what their coronary vascular health looks like, their cardiovascular health looks like, what their, breast imaging has looked like in the past, all of that. And we have a discussion about it, but I think that, sometimes some of these things are missed. And so really looking at the vulva, the vagina, the vestibule, the clitoris, all that stuff is really important.
So, we have a lot going on. And for any woman who's going through this journey where, maybe they don't have that older maternal figure to look to like they did maybe when they were a little girl getting ready to go
Yeah.
through puberty for the first time. Would you say there's maybe 1 to 3 questions you would encourage every woman to be asking when they are at this stage in life to their gynecologist?
I mean, maybe just having there's some questionnaires that are on like the Menopause Society website that you can actually like download and answer. And sometimes some of us give it in the office, but it kind of like reviews, like, because it's something that affects women from head to toe. It's just not hot flashes or night sweats, which can be very debilitating. Sleep disturbance, it's weight gain, it's visceral fat, like midsection weight gain specifically. It's dry skin, dry eyes, it's hair loss, it's everyone listening in their 20s is like, oh great, what do I have to look forward to? But it's also like those genital urinary symptoms, urgency, frequency, painful sex. A lot of that can happen. Now some people breeze through menopause and that's wonderful, but we know that there's all these things that can be happening that we should address. And I feel like just understanding like what changes are happening with you, like is your menstrual cycle. I would say that I talk about these top 3 B's of perimenopause that like gets people thinking. Like one, is there a difference in how you've been bleeding menstrually, right? So the B for bleeding, like have you started to have like shorter duration between your menses, or longer duration, or heavier menses? Like so tracking your cycle is really good. Actually, some people use like different apps for that. Then the other one is brain, like what's happening to me mentally that's different, right? So brain fog is, that sensation of like, I can't remember the next word I was going to say, or I walked into a room and I don't know why. that is actually very debilitating. I've had patients who tell me they're in the middle of a speech in front of people and they just froze because they couldn't remember what they were going to say. Like, this is like stuff affecting people's quality of life big time. There's irritability, like how sometimes during your cycle you feel like you just hate your significant other and it's really, causing a problem. Anxiety symptoms, depressive symptoms, crying for no reason, all of that, is brain related, right? Because there's some changes happening in our brain during perimenopause. And then the burning is the third B that I talk about. And burning in the sense of, like you get a surge of heat or you're sweating all the time, like this vasomotor symptoms, but also like burning in the vagina, like, right? Like all of a sudden I feel a little dry, it doesn't feel comfortable, it hurts to have sex, that kind of thing. So those are kind of like three like benchmarks that I give patients, like, are these happening? Because perimenopause is a clinical diagnosis. We should say that. Like, people ask to get their hormones checked. I often will check them just to show them what it looks like, but they're not fruitful in a diagnosis. It just tells us like, okay, this must be a month that you had really high estrogen because your estrogen is really high, but the next month, oh, it's really super low. But I think understanding that, you have to be in tune to what's happening to your body to get the best answers for you. So if you don't know, like, oh, actually, I didn't track my last cycle, or I don't know if that's happening. Most of my patients know exactly what's going on. They're very well read nowadays because everything is out there, talking about perimenopause and menopause. So I feel like, there's a lot happening right now that's beneficial for women in that respect.
Well, it sounds like there's a lot to dive in on in regards to all of that. And
Yes.
we have some great resources to point women to in that case. As we get ready to wrap this up, is there ever a time a woman is supposed to stop seeing the gynecologist?
That's a question I get asked a lot. I actually do not think so. I think you should continue to see a gynecologist until death do you part, because I'll tell you why. Because sometimes I'll have patients that come in to see me and they're like, the last time I saw a gynecologist, some of them might be breast cancer survivors, or they might be previvors, right? Where they had a prophylactic mastectomy and then they had their ovaries out and they've had their uterus out. And they're like, Dr. Rahman, I really don't have any female organs left. So I don't even know if I need to see you anymore. I said, you have a vulva, you have a clitoris, and you have a pelvic floor and a vagina. Those are things that I can still evaluate for you because they're oftentimes what get missed the most. And so I think that, especially if it's a gynecologist who kind of specializes in this arena, like to go see someone that's like purely an obstetrician, of course, like you probably don't need to see an obstetrician anymore, but I have like 70, 80-year-old patients coming to me all the time, like, and they're, fully taken care of by a cardiologist or an internist, but I'm going to manage what's happening elsewhere.
Thank you so much.
Yeah.
Are there any final things that you would like to say to the listeners while they are all ears with you right now?
Yeah, I really like to emphasize that understanding your own health and what's normal and not normal for you is one of the best steps to advocating for yourself, right? Because like I always say, like, of course, like, I have a lot of knowledge when it comes to this stuff, but you have the most knowledge about your body, right? Like about you, what's happening with you. So you need to tell me, like, in the most descriptive words possible of what's happening. And that's really going to be the next step to advocating for yourself the best. Because in this day and age, the way medicine is running and the way it's going, and people, private equity are buying out private practices, and the hospital systems are really getting more and more interlinked with the bottom line, which is how much money they're making. It's really compromising, I think, care, and the people that get it the worst are women, right? We're going to get shat on the most, right? So we have to advocate for ourselves. And if you're not finding anyone, if your clinician is not listening to you, you have to, number one, point it out. I don't feel like you're listening to me. Like, it gets uncomfortable, but sometimes just naming it and calling it out can be helpful. And then other times, a good clinician will say, you know what, this is not my area of expertise. Like, I need to point you into a direction of someone that can help you. But I feel like, those two things are really important, like learning how to advocate for yourself. Sometimes, and I think that's why, like, things like, there's so many coaches that are coming up now as like, almost really as patient advocates, right? To help them kind of navigate through these difficult times in a system that doesn't give patients enough time that they need with to get their problems taken care of.
Thank you.
Thank you so much for having me.
Thank you for listening to the Dangerous Women podcast. If you had any groundbreaking takeaways from today's episode, please tag us on social at the Dangerous Women podcast. To make sure you never miss an episode, subscribe below.